Our next and last speaker for the panel this afternoon is Dr. Jeffrey Marks, who is professor of surgery at Case Western Reserve University. He is the program director of the general surgery residency there and director of surgical endoscopy. For SAGES, he has been widely known for helping to pioneer and innovate the FES, Fundamentals of Endoscopic Surgery curriculum. Today he is here to talk about FES and towards assuring competency. Welcome, Dr. Marks.
Okay. Thank you. And I commend those of you sticking around on the last day of the meeting. It's always hard. Things kind of get a little bit busy for all of us. Anyways, so I want to thank Dr. Bittners and AWAD for inviting me to talk about FES and how this is going to lead the pathway towards getting competency, which is a tough problem probably for all of us. These are my disclosures. I think none of this will impact obviously what I'm talking about. I think the biggest disclaimer though that I probably should give all of you is when I was asked to do FES, it was as a surgical endoscopist were my skills, not as an educator. And I think the speakers that you've seen already have a big step ahead of me in terms of being surgical educators, but it is something that I've learned a lot on over the last 9 years. So a couple of definitions that I want to give you, at least based on how I would look at things in terms of the FES and FEC, but competency is really kind of getting to that point of being adequately or well qualified, okay, both physically and mentally or intellectually, and possession of that skill such that they will be able to complete a task. And this is the holy grail. How do we know that they've completed the task and whether it's successful or not? The other definitions, for those of you maybe that have not heard, FES and FEC are two different things. FES is the actual Fundamentals of Endoscopic Surgery test. FEC is the Flexible Endoscopic Curriculum, which enrolls FES as one of its assessment tools. So why FES? Why do we have this? Well, basically, if you look at 1995, endoscopy was not terribly common. Only about 10 people that were recertifying reported doing it, whereas in 2007, now all of a sudden we're at over half the people recertifying did endoscopy, and it was the second most common procedure being done after abdominal wall or hernias. And this has changed for this upcoming year, but it is part of our surgical practice. It's something that we do, but we really are kind of at a loss as to how to actually assess this. So the premise behind FEC and FES was basically that all surgical residents and practicing GI surgeons would require to be competent in this skill set. We operate on the outside of the GI tract, we need to operate on the inside of the GI tract, but it was definitely a dilemma for program directors. You know, now all of a sudden with the mandate with Jeff Ponsky as the ABS president, we upped the numbers, although they weren't that high. So they had the dilemma of having to gain these numbers of cases, decreased resident work hours, obviously limited endoscopy, which is only one of 300 actual skill sets, but now we have a whole curriculum for one procedure. We know about the mandate for simulation, which is important, and so we had to come up with some way to match that as well. And the concept of assessing competence, I mean, again, that holy grail in endoscopy, it's been a big problem because of the fact that we really didn't know where to go with that, and so that's where the whole FES and FEC premise came from. So FES originated in 2006. It was an idea by Bruce Shermer. At the end of our board meeting, we were looking at the congratulations of FLS. It was wonderful, and Bruce raised his hand. He said we have to have FES. At the time, Nat Soper was our president, and at the end of the meeting, out of probably some ignorance, I said, hey, let me do that. I'd love to take this task on, even though I didn't really know much about education, and that obviously was 9 years of my life ago. Basically, we were lucky. FLS took a long time to put together, all right? When Lee Swanstrom came up with this idea with Nat Soper and Lee Sillen and a bunch of others, they really had no platform to work on. So we were lucky. We could build on the mistakes and the credit what FLS did to build this, and it's basically three things. It's a comprehensive, web-based didactic, which you all can see. It's free. It's online right now. In fact, we're working on FES 2.0, which will hopefully come out by the end of next year or early 2017. But this basically was a didactic overview of gastroenterology and surgery put together as endoscopy. There's a high-stakes written exam that went through beta testing, similar to FLS, as well as a hands-on exam. The target candidate was the most important thing. So before we even started making anything, the important thing to understand is FES is aimed at a PGY3 after they've completed their endoscopic rotation, or a first-year fellow at the completion of a GI fellowship between their first and second years. FES is only a test. It's not a training tool, other than the didactics can be used for training, and it's an integral component of that whole flexible endoscopy curriculum, both of which are being mandated for your 2018 residents. So that's your PGY2s completing their year this year. So overall, the American Board of Surgery, we approached them back in 2011. This became a mandate for the class, as I said, of 2018. And it was put together with Brian Duncan's leadership in terms of this flexible endoscopic curriculum to come up with a whole 5-year plan. And this was the first thing, in my mind, which was the stepping stone for the American Board to get to tracking. We will go ahead, give them milestones, we'll give them some ideas of how to get to, go to this core surgical training, and then people that could go off. Because overall, I mean, if you're gonna go on to breast or to vascular, do you really need to do FES? And there may be some programs down the road or changes that those people really won't have to, I think, probably pass FES or go through the FEC to actually be board eligible. But basically, the technical and cognitive milestones were things that we took off the shelf, including a lot from SCORE, a lot from FES, as well as other textbooks, and the technical skills practice models are things that are in process right now. The hard part is, as I said, FES is a test, unlike FLS, where you can train on the box as much as you want and get to a level of proficiency. Matt Ritter and Danny Scott put together a whole idea of proficiency testing so that you would know that you would pass. Well, we don't have that with FES, but right now, SAGES has sponsored 4 research studies to go ahead and look for proficiency testing on boxes. You don't need to buy a simulator to be able to train to do FES. And in fact, we don't let you do the FES modules until you actually are taking the test. There was some fear that gaming would occur, and we didn't want people to be able to game the system on a VR platform. Obviously, clinical experience is a vital part of any training program, whether it be for surgery, for endoscopy, and so that's a component as well. And although it's stated that you need an endoscopy rotation on my slide, the American Board of Surgery Flex Endo curriculum says you only need endoscopy exposure. It doesn't say you have to have an actual rotation, although we do recommend a 1 to 2 month rotation. And this was put together with both the GI, the colorectal, as well as the surgical societies that you see listed here. So this Flex Endo curriculum, as I said, is now in effect as a mandate for your your outgoing second-year residents. So the concept of competency, and I will admit this was very hard for me to put this together, this talk, and Amy helped me a lot, Danny's PhD, because it's a really hard thing to assess in my mind. You know, the speakers before me, who have obviously much better knowledge base on these things, gave us some idea. But right now in flexible endoscopy, what is the standard of use is clinical exposure and case numbers. If you look at GI, privileging, it's based on how many cases that you do without any assessment tools whatsoever. The proctor assessment basically is a gestalt, so that in the GI community, and this is the scary thing, is that they don't even keep a case log. At the end of their 3-year fellowship, basically the program director says, yes, they're candidates, they can go on and do things. And so for all of these years, these decades that we've been fighting with the gastroenterologists over numbers, and we keep these obviously case logs with patient medical record numbers, there is no case log at all for gastroenterology. And when I heard about this about 6 months ago and was able to tell Frank the other day, I thought Frank Lewis was going to lose his mind. He was very calm, okay, but I thought that would really be something that would kind of bother him. But basically, the concept of numbers has always been an issue for us. And what about clinical performance indicators? Those also are very lacking when it comes to flexible endoscopy. So what do we have? So the methods for assessment that we have right now, well, we have case numbers. And these are obviously unaudited, okay? In the GI world, in the surgical world, they're not. But volume is utilized as a surrogate for competence. And we know for anything that we do, although yes, the more you do something, riding a bike, writing, all these things, the more you do, the better you're going to be, but it's unclear where you reach that learning curve, at least on endoscopy. In terms of the level of responsibility, the problem is that, as we discussed before, the idea of autonomy is not there, all right? So if a resident does a colonoscopy or a fellow does a colonoscopy, they will have a 100% cecal intubation rate because I'm not going to let them not get to the cecum. They're going to have a 100% adenoma detection rate because if you see a polyp, you're not going to say, oh, we're going to let you do the whole colonoscopy and I'll bring the patient back to take out that polyp. You're going to identify that for them. So there really is very limited level of responsibility that occurs with endoscopy and probably with surgery as well. As for the measure of quality of what we're doing, again, those ideas of cecal intubation and adenoma detection, again, they're not surrogates for clinical performance, but they are what we're using right now in terms of examining mucosa thoroughly, limiting withdrawal times for colonoscopy, and obviously being able to assess your patient and patient comfort are all important things for strategies for overcoming obstacles. In terms of the other method for assessment is the program director's signature, all right? And I've only been a program director for 3 years, and every time I sign that, it's a little bit of a shake because you always wonder, is this person gonna have appropriate clinical ability when they get out there? And I really think this is where we have to go, and I'll get to that in a little bit, is that it's not just in residency, but it's after it, that I think it's a very vital part of program directors. So, what do we need? We have numbers, we have program directors. We really needed a formal type of validated test, and that's where FES also gained its premise that it was pushed along just like FLS. So before we talk about all the great things in terms of assessment, I really want to talk about a lot of the limitations, okay, of the programs, to be very transparent, to kind of be honest about this. The hard part is when we did all of our beta testing for both the hands-on as well as the written exam, we had to use numbers as a surrogate for levels, for novice, intermediate, as well as for experts. And even though we differentiated them and we identified construct validity and the validity points for both the hands-on and the written were very strong, it definitely was something that was a big argument between myself and Dr. Freed and Dr. Vasiliou, because we're going back to numbers, which we wanted to get away from. In terms of where we were headed, though, with that PGY3 resident, it was for a minimum level of competency. We didn't want them to have to be an expert. We didn't want them to have to be as good as someone that has done 1,000 endoscopies. And we were also unclear what it meant in terms of outcomes. What was their level of cecal intubation, adenoma detection, and obviously clinical complications. In terms of outcomes, that's the hard part. FES, as I said, is a test. We have no outcomes yet in terms of clinical practice. So it would be wonderful that we go for the 5 years from 2018 to 2023 and see if we have changed clinical outcomes in terms of colon cancer rates, clinical outcomes of adenoma detection, and we see more of a post-residency kind of expectation rather than something during residency. Okay, what else? It's unclear what is technical competency. As I said before, no resident is going to go unaudited during a colonoscopy, and we think we do have some ideas. In my mind, when we looked at the hands-on portion for this exam, we took endoscopy and we deconstructed it. What are the components of it? It's not so much holding the grip and holding the handles and getting to the cecum, but more what are the different components of both upper and lower endoscopy, and also how do you skill assess this? So we went back to the basics and tried to make this a system where residents could go through this and be assessed for these basic scenarios. And that's, again, where the proficiency modules are going to be very important. Right now, to make sure that the residents will be able to pass FES, we need to know that we can get them up to a certain level. And each program is going to come up with a different game that they utilize, whether it be a box trainer with endoscopy, some other VR system, or, in fact, something just like clinical. The McGill people are looking at just clinical outcomes and seeing if the certain levels will allow them to pass FES. But we are going to be offering you guidance for training, and that's where the association with the American Board of Surgery and the APDS, next week at the APDS, there'll be one workshop and one panel looking at how program directors can go ahead and adopt FES and the FEC. So, what about cognitive milestones? Again, same idea. Endoscopy is a component of evaluation of GI digestive disorders. It's not just a procedure, but it's very hard for us to come up with the knowledge base and have outcomes from that. Again, if they learn everything that's in the FES didactics, does that make you a better physician? Well, we hope so, but flexible endoscopy is changing. When we started this 9 years ago, we were in the middle of the notes era. There was no poem, okay? There was no advanced ESD. There was no endoscopic full-thickness resection, and things change, and the hard part is we've made a tool that's very static. It was obviously started a while ago, and I think we need to be somewhat flexible with this tool to be able to catch things up. The same way that things will change for our residents. Screening colonoscopy won't be here in 15 years. Within 15 years, we'll have either genetic testing or radiographic type of imaging that will replace screening colonoscopy. So again, the whole concept of being able to do colonoscopy will change, and it's going to become a therapeutic procedure, not a diagnostic procedure. So what about gauges? The global assessment of GI endoscopy system, similar to goals for our laparoscopic skills, gauges was a component that we had to create to do a clinical assessment tool. And this also was put through validation and showed some important things. But the issue was this was an assessment tool by 2 observers, and there was good inter-rater reliability, but we never really had a train the trainers program so that you were given a gauges sheet, you rated your residents or your fellows, but again, it was kind of lacking some quality metrics that were cited by the GI people. We didn't want to look at adenoma detection rate, although we do have mucosal evaluation, and cecal intubation per se wasn't a metric on the 5-point Likert scale for these, but basically it was completion of the procedure. So there was some criticism from the people following the CEDLAC group, okay, in terms of other assessment tools for colonoscopy. In terms of correlation of gauges scores and clinical outcomes, we don't have that. We do know that gauges scores can be used, and basically what identified, there was about 57 colonoscopies that people plateaued on the gauges scores, and that was, again, Milena Vassiliou's work. And so we've shown that you don't need 500 colonoscopies to get probably someone to a minimal level of competency, but again, clinical outcomes are still yet to be determined. So, what are we doing towards this cesarean competency? Well, first off, I think at most we can say this is a snapshot, all right? It's a one-test day, both didactics and hands-on. I think the FEC, the Flex Endo curriculum, will help us gain competency as a whole five-year-long milestone-based process. This has to be a longitudinal assessment. So part of the FEC isn't just one test, it's assessment with gauges on several steps along the way, as well as clinical assessment. But I do believe that we are very lacking in terms of this whole longitudinal assessment when it comes to residents. And there's a lot of gestalt that goes along with the idea of passing our residents from one year to the next, because the idea of remediation is not easy. All right? We don't really do it very well. At least I don't see it being done very well. In terms of what further research we need, well, we need the ideal curriculum. Right now, when Brian, Duncan, and I put together the FEC, we really didn't have any clinical basis for it. We put together what we thought was important. We gave program directors an idea of what they could utilize, but it needs to be matched to actual clinical outcomes and clinical experience. Same thing with the cognitive component. It is a moving target, and as I said, we're working on FES 2.0 right now, which I think is important, as well as the proficiency modules, which will really allow us to be able to get people up to the point of passing FES. And finally, I think what's going to have to be the real goal for research is that we're going to have to look at either, whether it be NISQIP or some type of clinical outcome measurement, pre and post FES and FEC. Not that they'll be able to take all the credit. I'm sure there'll be a lot of variables when it comes to that type of study, but I think that would be our goal when it comes to any type of assessment test like FES. So where are we right now? So again, the mountaineering thing, for those of you that saw Ed Viesters give his talk on Thursday, I mean, I was like a groupie running up there to talk to this gentleman, because this is a guy who's about my age who, as you heard, has climbed all 8,000 meter peaks without oxygen, okay? And it's just an amazing thing. But right now I say we're about right here, okay? This is us at about, I'd say 25,000 feet at most. This is gastroenterology, so you'll be happy to know they're behind us, okay? They have no clinical assessment tools. We are roped together because I want to drag them up the mountain as well and improve all of the patient outcomes. But the idea of getting to the point where we're actually on the top like this, I don't know. I'm not sure that we're ever going to get to that, at least by just FES and FEC. I think it's going to take a lot of changes that the American board is very attentive to in terms of getting people designated to the training that we'll need for them to get, obviously, the best patient outcomes. Thanks a lot.
All right, thank you, Dr. Marks. I'd like to welcome all of our panelists back up to the stage. And for our audience members, we ask that you either come up to the microphone if you have a question. It is a cozy group, so you can stay where you are and just talk loudly. We're also seeing no questions submitted via the app. I'll first start and see if there's any questions from the audience. Dr. Selzer, welcome.
So Don Seltzer from Indianapolis. I'm going to start off with a very inflammatory question. Are the tools available to make it so that we, well, let me rephrase this. Is it possible to train everybody that wants to be a surgeon to be a surgeon?
Who wants to take that one?
I'll take it. Depends what your definition of being a surgeon is, because I think part of it is that end of residency, we have trained the complete surgeon. I don't think we have. I'm a few years out of training. I'm still getting better. I expect to continue to get better because I'm going to be doing more and more. So it's about lifelong learning. So that's the first point to make, that we're not training the expert to then go out and stand on top of Everest at the end of residency. We need to define what is the standard of care that we want to achieve in terms of independent practice. I think we have a pretty clear idea of that. And then that's where we move back from to say, well, these are the tools that we need. And yes, I do think we have the tools to be able to train everyone up to that level.
I think implicit in your question is it's possible to select correctly every categorical PGY1 who is suitable for completion of general surgery training. And related to that, once you've done that, is it possible to ensure that at the end of that process you've really done the right job to produce someone who is able to be a general surgeon in independent practice? As program director, having told people who matched to the categorical spots they could not continue their training, I want to say that the answer is no, but it implies that I'm declaring that there's no way to salvage that person or to remediate them effectively. It's just that I'm at the point I'm giving them that information. I'm not willing to take that job on because there's a lot of uncertainty as to what the endpoint would be. So in the real world, I think the answer is no, it's not possible unless we have a perfect selection process.
I would basically say that learning doesn't stop when they get their certificate. And I think one of the things, maybe it's the easy answer, is that we're not training just for 5 to 7 or 8 years. These people should be made into being learners so they learn afterwards too. I think for all of you that have been out for a while, I'm sure every decade or every 5 years, you reach another milestone, okay, or a learning curve. At least I think that's been for my career for 25 years. And I think learning now is different than what it was 100 years ago. I know Frank Lewis talked about this the other day, that we haven't changed anything. There was no, 20 years ago, there was no online data. There was no, easy access for these things. And I think we have to take advantage of where we are here right now with the resources for our outgoing residents.
Any other questions? If not, Mary, I was going to ask you, when we roll these programs out across a larger number of programs across the country, some will be in a great position like WashU to be able to offer specialized training across a myriad of disciplines, and others are clearly not because of their size or location or what have you. So do you see those types of programs that can offer that specialized training, the types that applicants will go to if they want specialty training, and the other types will be the general surgery programs?
I think that's a great question, and I think a couple thoughts in response to that. One is that even within the 9 programs that are in this little prospective study, they're all large and for the most part well-resourced academic programs. We even have struggles providing an adequate experience in a given specialty, in large part because we can't control the numbers of residents from class to class that might want to specialize in a given field. So, if I've got 3 people who want to do HPB in 1 year, it can be really difficult to make certain that I have an adequate volume to go around. And one idea is that we would have some sort of permission from the RRC and the board that there would be some swapping of residents at the senior level between residency programs, some sort of consortium that allows that sort of flexibility. To date, that's not been approved. That was a question early on in the formulation of this group that we all had, and the feeling was we would just work within the existing rules, sort of get off the ground, and then see what what comes up. But even in the future, it's not just the well-resourced programs that can do it. It's really being able to do it and meeting the variability interests of the trainees. This question was raised yesterday in the Fellowship Council luncheon, and my personal feeling is that we need to shy away from a system that has the surgical education community essentially sort of pitted against itself. I really worry that programs that can do this versus those that can't will create some competition and some tiering. I do think historically we've always had residency programs that have tended to train general surgeons. Gunderson Clinic in Wisconsin is a great example of that. Almost nobody goes on to fellowship training in that program. So there already are some programs that tend to attract residents who desire careers in general surgery. I think we need to somehow increase the cachet and value of a general surgical career. I'm not really sure how to do that other than to change reimbursement, and I think trainees to some degree also follow the dollars. Getting more mentorship in general surgery in some of the residency programs and getting more true general surgery rotations in some programs I think may help that. But my personal feeling is that we need to shy away from having programs that are just training general surgeons and then those that are just training specialists.
The back second microphone, go ahead.
Dr. Watanabe at Hokkaido University in Japan. So thank you for excellent presentation. I have two questions. First question is a very specific question. So in Japan, we don't have a structured surgical training system. So basically, I would like to assess the surgical training system or quality of surgical training using like surgical training quality assessment, SQUAT, Dr. Agawar. So basically my question is how to use and how to implement the data and how to improve the quality of training according to these assessments.
Thanks, Yusuke. You actually, in Japan, have something which is unique. The Japanese Society for Endoscopic Surgery, practicing GI surgeons. To get into that club, you don't just submit your membership and pay your dues. You also have to send 2 videos of a defined case, which are then reviewed by the membership committee, and they decide whether you are then allowed into that club using a rating scale. And about 60% of people get in, and 40% of people don't. Now, that's not answering your question in terms of quality of direct residency education, but it obviously is when you look back at David Ash's paper. This is actually looking at the process of patient care when you're an attending, and this is then defined as a mark of getting into that club. And then it relates more closely to the recent data that John Berkmeyer published from University of Michigan, that you can actually use videos to rate the technical quality of performing part of a gastric bypass and how that relates to outcomes. So in some ways, Japan is very much ahead of the game, and you've been doing this for, I don't know, 8 years or something like that. So I think that's phenomenal in terms of surgeons in practice. In terms of more directly answering your question, how to use this SQAT scale, we're just doing a pilot study in a region in the UK. And as you saw, there's a number of biases. You're asking essentially faculty in their own program, what is the program like? That's a bias. We didn't get very good response rate. And then the Joint Committee for Surgical Training is asking the trainees, what do they think? But I think it's really beginning to ask the question more broadly. In the US, we have the Residency Review Committee, which is a process. And so, all of the above, the RRC, the SQAT that I mentioned, the stuff that's going on in Japan, I think are all ingredients. And the ultimate is the work that David Ash has done, are all ingredients for us to improve the quality of surgical education.
Thank you. Second question is, I think it is very hard to compare the clinical outcome and the simulation-based assessments such as FES or FES. So is there any way to compare the clinical outcome and FES score or FLS scores? Maybe there is no evidence out there. So
So he's
Sorry, sorry, Chair.
No, go ahead. Yeah, I think the question was about comparing clinical outcomes
Yeah, exactly.
with FES and FLS.
Is there evidence?
And anybody, Dr. Marks, you want to take that?
Yeah, I'm not sure that we have an answer just yet. That's kind of my concern, is that we will put people through all of these assessment tools and we'll find that it doesn't change things, like you saw in a couple of the talks where people were going through different VR-based training and it didn't change things. But I think even if it gets residents and surgeons doing more cases, doing more didactic work in endoscopy, it can't have a negative effect, all right? And so hopefully that will, again, allow them to improve patient safety and patient outcomes.
Thank you.
Yeah, agreed. And, I think that the complexity of studying all but the most focused outcomes that might be directly affected by a training intervention gets into an area where there's potentially too many other factors that may influence the outcome. And of course, once the result is diluted in that way, you're left with a negative result of a study from which you can't necessarily conclude that the intervention was without value, just that you couldn't demonstrate the value using the assessment tool at the clinical end that you designed.
Hi, Amy Gardner, Dallas. I guess I was just thinking about, we're talking about competency-based training, and for that we're trying to equip all of our learners with these new curricula and, having them improve their skills. But as I think about, FLS and FES and now FES, do you think we should get used to all of these different certificates and these, kind of hurdles for us to assess our learners? Like, is that the future of surgical education now? I guess that's, probably open to anyone on the panel. But I guess what are your thoughts surrounding that? Should we just get used to, okay, the PGY 1s, they're always going to have to be, demonstrate their competence in this, this, and this, and then PGY 2s, this, this, and this. I guess what are your thoughts as surgical educators on us moving that direction? And, is there going to be a point of where we go too far?
I'll take a stab at that first. That is my personal preference for residency redesign, actually, is that there are individual PGY year targets you have to meet or you're not allowed to move forward. It's very much a competency-based training algorithm. It will be products like those that SAGES has developed along the line for some components that will sort of roll up certain skills. But I even think something like what we've termed a rolling ab site. So for instance, as a junior resident, there's these 8 sections of the ab site you have to master before you can get out of your PGY 2 year. You can take it whenever you want, but you've got to achieve a certain level of competency. I personally think it's very much here to stay.
I think as probably the most recent of those who've trained up here, serving as the trainee and then now as a trainer, I think having the expectations set in advance helps you identify not only what you need to learn, but potentially how to learn it, so that if you don't have a world-class surgical endoscopist in your institution who's going to show you how to do this, you know what everybody else is going to know, you know what the expectations are, and you can train accordingly. And I think it helps, while there may not be data yet, I think ultimately it helps graduates feel more comfortable with their skills, because those skills are somewhat standardized across the country based on these training paradigms.
So I have another question. So a comment first. Neil, in your talk, you talked about VOPs. And obviously Gary Dunnington is now my chair at IU, and so we try VOPs, and I can tell you that it's not scalable. It's not easy to go from 3 residents a year like they have at SIU up to 10, and it isn't easy unless you have faculty investment to get it done. It's very, very hard for our program to make the VOP process work as Gary has moved over to IU and Reed has moved with him somewhat. So it isn't really a question but a comment, but more along those lines. Jeff, you mentioned remediation, and so if we are setting milestones, that means remediation. And so when you think about remediation, you think about the process to remediate. And so, Jeff, you mentioned we don't do it very well, but we need to develop our remediation skills, which means we need to figure out better how to teach those skills so then we know where we failed. So I'd like a comment from the panel on that, and then maybe Raj about your talk. How do we select which faculties do the faculty members do the remediation? Many times it's just thrust upon the skills lab director. It's their responsibility if it's technical, or it's thrust upon the program director if it's professional, because ultimately it's their responsibility, but maybe that's not the right person to do those things. Is there a way to even figure that out?
I just want to say first, I completely commiserate on the difficulty of doing VOP as Gary described it, implemented at SIU, and we don't do it either. And we don't, always use the term remediation to define what we do, in effect, do instead, which is, you modulate the intensity of training for someone where there's some slowness to acquire the skill, or if we think that a resident isn't keeping up with the requirement for what we would ordinarily demand for progression, particularly between the PGY 2 and 3 level. So there's a lot of individualization of training effort directed at specific residents based on the training data, but as the SIU experience defined VOP, we don't do it either for I think some of the same reasons that you're alluding to.
Don, thanks. I mean, Jeff brought it up as well in terms of faculty development, and there was a great, I think it was an editorial written by Rebecca Minter recently in the Annals of Surgery about improving quality of surgical education, and a real area that we need to focus on is faculty development, not only in terms of enhancing training, and the standard is if you're an attending then you're a surgical educator, which obviously is incorrect, but also in terms of, as Jeff mentioned, in terms of being able to rate performance and then being able to have those difficult conversations. They are all things that we need to learn how to do, and we are learning to do that through experience, and it's just like anything else. It'll bring me to something that's, I think, slightly related. There's a palliative care physician at Dana-Farber Cancer Center who says breaking bad news is a procedure, just like learning how to operate. And in that same way, being a surgical educator is something that is a procedure, and we need to learn how to do that. And so there is now, a number of surgical educators. There are opportunities to go into scholarship and so forth, and those are beginning to be thrust forward. So we need to continue in that domain.
All right, I'm afraid that we are out of time for this afternoon. I want to thank all of our panelists for a very wonderful and engaging presentation and discussion. Thank all the audience members for also your questions and for sticking with us till the end. Thank my co-chair, JB, for organizing this session. Thank you again, and safe travels to everyone.